right. Hey, everybody. Let's go ahead and share my screen and we'll get back to where we were in our chapter 10 lectures. So we're going to talk about a little bit about healthcare and particularly some of the challenges that we face. Um, First off, there's a super uneven distribution of doctors, and there's a lot of reasons for that, right? It's difficult to motivate doctors to go to rural areas because they know they can get paid more and or have more likelihood to have their own business and to have more clients accessible in larger cities. On top of that, the urban areas have an abundance of physicians. So you're more likely to have maybe a physician or a specialist that you need if you're in a more urban area than you are if you're in a rural area. This also is different depending on the state you live in, right? So, for example, like I currently reside in Oklahoma. My kiddo, who is medically complex, right, requires a pediatric rheumatologist, but there's only one in the whole state. And so if you can't get in with them, or if there's an issue there, you have to go out of state, but you can only go 50 in a 50-mile radius surrounding. And if you look at the map, like it shows even that Oklahoma is one of those states that it is the fewest doctors per capita. And what that happens is that when you have cases like my kiddos or like anybody else who needs a particular type of specialist, it leaves you really hurting for the kind of care you need, and it leaves you really vulnerable to medical instability. And that can have really long-term effects, both medically and also financially and economically, if you're having to travel long distances to go to the doctor, or you're having to, you're not able to get to your specialist that you need. And then you have further medical issues that cause you hospitalization or et cetera, or more lasting damage. The rural areas and or the states that have laws that really don't protect doctors' liabilities. So say you have, or for instance, there's policies that really have implications that haven't really been worked out. So like when we talk about reproductive health, we talked about some of those states that were really restrictive, and the more restrictive you get, the more likely it is to have these overlaps where there's liability concerns and or gray area that hasn't really been legally sussed out yet. And that's going to make doctors hesitant to want to practice in these areas. And so really, this particular setup leaves these areas really vulnerable and the patients within those areas really vulnerable. And so really, like your book talks about some of the solutions to this really becoming, making or figuring out ways in which you can motivate doctors to come that way, whether it's programs to help with the cost of education, whether it's programs to help draw doctors to different areas. All of these things and initiatives, oh, I'm sorry. All of these initiatives can really help to kind of even out the distribution of doctors and where they, and that way the coverage of care is more consistent. So moving on to mental illness, when we talk about mental illness and or mental health, the way we measure mental health can get really hard to quantify. And the problems with that is that take any mental health ailment or something that has a diagnosis to it, and there's going to be either multiple tiers or a range of how dramatic the symptoms are, and or the symptoms are going to be very different depending on the person, and they're going to present differently. And we do have some science that explains that there are some brain chemistries that result in different kind of emotional upheaval and or a different way to process, or our brain processes. But the more we learn too, the more we're understanding that environmental impacts and or even like just behaviors and or trauma, all of these histories, these biographies are intertwined in very, very specific ways that create and or limit the ability for mental health care and for practices that, or even a society that focuses on the well-being of those who are a part of it. We also have record-keeping issues when it comes to the rates of mental health due to these social stigmas that are surrounding it. So we really have a hard time measuring the rates of how often things happen in society. If there's a society that tends to shun it or say it's a personal problem that should be handled by yourself, and or if it's something that you should kind of shove under a rug. And so, like in America, we have a really big issue with limiting essentially who can have mental health issues. And part of that is our construction of the way we construct gender. And so for men, it is incredibly hard to consistently talk about and or get treated for mental health crises, because there is this understanding or notion that supposedly men are supposed to be these really tough people who don't have who keep all their emotions in check. And what ends up happening is that there's a lot of consequences for doing that, because humans aren't meant to do that. And so that creates this situation or this societal norm that really has a negative impact on humans. And it also has a negative impact on really being able to assess how much of a social problem it is, because of the way in which individuals are told to keep that under wraps, or to keep that to themselves, or to not seek out help for that. Measuring mental health is also very subjective, right? So the way in which somebody describes their own feelings, while yes is valid, can be inconsistent across the board, right? So it's the same when individuals are asked to measure pain, or to associate pain with a certain thing, a pain scale with a certain thing. Those pain scales are going to be different and varying for every person. The same is going to be true of mental health and or the symptoms we experience, right? The level to which we experience those may range very dramatically. And it's hard to subjectively, as an outsider, get a fix on how those relate to each other, or how all of these patients, say you have a bunch of them who are experiencing similar kind of phenomenon, how that phenomenon is similar, and in what ways is it manifesting, and is there a varying degree to which it manifests, and all of these things. These are really subjective measures, and because of that, it makes it really hard to kind of get a full grasp of what is happening through a society as a whole and on a larger picture. And it also makes it harder to garner the funds to do research, and or to figure out if medications are working, and or to figure out what it is you're trying to medicate, right? If you can't very objectively pinpoint what it is you're trying to treat, it makes it very hard to figure out what kind of substances would interact with that particular chemistry, or that particular thing that you are trying to draw attention to. We also, again, have a two-tiered mental health care system, which really leaves essentially those without insurance, and or those who have limited insurance, and or those who have really economic struggles, being treated through like medications, as or through like, here's your anti-anxiety meds, go do life, right? And or they have this limited ability to garner time even for some resources, because while some may be available, it's going to be harder for them to take off work, or to have childcare, or whatever you need in order to access those resources. Whereas wealthy individuals are going to be able to experience, and on a grander scale, are much more likely to have individual counseling, and for a length of time, for as long of a length of time as they need. You're also going to see a significant amount of like people being validated, the more wealthy they are, as opposed to being invalidated the less wealthy they are. And then again, the social nature of mental illness. So we talked a little bit about this already, but like, there are stressors, there are social norms that put pressures on individuals that really lead to negative mental health outcomes. And again, mental health is presumed to be the primary reason for suicide, or taking one's own life. However, there are other social reasons, right? There are going to be social pressures that are put on. There's going to be mental health isn't always um, a result of a chemical imbalance. Sometimes it's a result of trauma that is a direct result of societal norms, or say violence against women, for example, or the rates of sexual assault that happen in this country. Those things are going to put pressures on people and those individuals as they are working through said trauma, or as even those that just have the normal economic pressures of, I have to be able to pay my bills, or what am I going to do now, or I'm going to get evicted, or how am I going to keep a roof over my kid's head, et cetera, et cetera, et cetera. Those pressures build up. And as those pressures build up, it makes it really hard to continue to trek on. And these are things that can result in an individual wanting to take their own life. And again, we talked a little bit about this in the suicide section, but if there is a reason, or if there is if that is something that you struggle with, there are resources out there, and please reach out so that we can get those to you. As well, you're going to see a lot of homelessness with those who have any kind of mental ailment, or any kind of uh, mental health struggles. And that's just, again, going to be a result of whether or not you can receive treatment, whether or not you are economically stable, whether or not the symptoms that you experience allow you to be economically stable or hold a job. And all of these things, and the amount of social stigma that they carry, all of these things then impact somebody's ability to get housing and or keep housing. And then lastly, again, there's a lot of conversation surrounding this, but there's more and more conversations about how serving in the military impacts your mental health and the long-term outcomes for those who experience that. And this is something that is getting a little better, especially since, like, I can remember when I was younger. I have several military members in my family, and there's a very real difference that even they will talk about. Hey, I'm seeing the difference between people getting help now versus the people that I served with, or those situations, and how that has changed. And that's a really good thing. And I think it will cross over into more conversations surrounding overall mental health within the male population. And so hopefully that can kind of bridge maybe some of those social gaps and social norms surrounding treatment of mental health. On the flip side, it also sets up this standard that there is a level of trauma to which someone has to go through that has to be adhered to that military level in order to really be expected to have any kind of mental health negative outcomes. And so that also sets up this double standard, right? So this there's on one side really good that we're having these conversations and that those are getting that those people are getting help. On the flip side, it's also leaving those who maybe men who maybe experience child abuse, or even sexual assault, or even just have the normal life social pressures that cause any kind of negative mental health outcome, to feel like they have to be in that setting, or that is the standard to which you have to reach in order to receive care. And that if you don't, then you need to just get over it, because I mean, look at them, they're still getting over it and they're still doing this. So there has to be this lack of comparison and really individualization of care in order to really kind of assess the needs of those who have any kind of mental health outcomes that aren't positive, or that they want treated. All right, so we're going to talk a little bit about infectious disease. The book really talks about HIV and AIDS. Obviously, we're having much broader conversations about infectious disease since the pandemic, and this book does not include a lot of that. However, because I do have an immune compromised medically complex kiddo. This is something that I have dug into in a very big way in order to kind of keep my own kiddo safe, and to keep my own kiddo as healthy as I can. So if for some reason you do want to have a conversation about how the pandemic itself and COVID-19 is really changing, social health measures, changing how we talk about infectious disease, changing how we talk about pandemics as a whole, and just the way in which there is a global dynamic now that we have to consider. Please don't hesitate to reach out. That is a topic that I talk about regularly and have no problem having conversations about. So overall, there has been a decline in infectious disease when you look across recorded human history. Now, part of that, and the majority of that, is drawn down to hygiene, right? So when indoor plumbing started happening, when we had sewer systems, when we had the ability to filter water, when we had the ability to have antibacterial or antimicrobials, cleaners, all of these things have helped to manifest certain kinds of hygienic levels that were just not available at certain times. So when you talk about like the Black Plague, or when you talk about the bubonic plague, some of these more these older kinds of infectious disease problems, there were just not quite the same measures, even when you talk about hygiene and medicine, right? So just the wearing of gloves, the wearing of PPE, the wearing of and or just washing their hands before surgeries and things have really, really cut back on infection rates in any kind of medical treatment too. So you've had a lot of hygiene related conversations that really and practices that have really changed how infectious disease is spread. Now, on the flip note, on the flip side, you're also seeing more resistance within the viruses themselves, right? Because they're going to mutate and they're going to do whatever they need to survive. Because that's not on a cognitive level, but just because that's what living organisms do. And so when we do see that, what we see is a need for that more modern medications, those vaccines, the technology, the treatments, those anti-viral medications, right? And you saw a lot of these processes happen throughout the pandemic. And it's a really good example, a modern example of seeing where infectious disease is still something that we have to have conversations about. And that there are social practices that can make a very big difference between, say, like how New Zealand handled the pandemic versus the US, and when you see those numbers and when you see how they got to carry out life, and the differences between that and why those policies were working, right? And when you look at those, there's going to be a lot of social factors. There's going to be a lot of particular kinds of pressures and policies, and all of those things are going to intertwine with public health data and actual medical intervention that really will make or break in any particular infectious disease outbreak. And again, I could talk about the pandemic a whole bunch, especially when it comes to masking and really the cultural conversation that really happened in this country and resistance to any kind of societal level protective measures compared to the individual level, and really how that conversation is different globally and between different countries, and how that had an impact on both public health policies, but also had an impact on the actual physical numbers of those who were sick and or died. Okay, well, let's get to the example that was talked about in the book. And they talked a lot about AIDS and HIV and AIDS. HIV, for those of you who don't know, is the virus that ends up causing the immunodeficiency that becomes AIDS, right? So you have to get this virus first, and then over the course of the process, it does a significant amount of damage to your body, and that body then starts to have an immune deficiency that allows you to be susceptible to things like pneumonia and things like that end up generally killing the individual. Now, there's been a lot of medical advancements since HIV and AIDS came out. Infectious disease apparently is something that's always been interesting to me because I used to be an HIV/AIDS educator when I was in high school. Now, this was a long time ago. However, before a lot of these medications, oh my gosh, that was a really long time ago. Not the point. But so it's interesting to read this now and the different takes that are being taken on it now than versus what just the basic levels of infectious disease prevention that we were talking about when I was giving the lectures on this back in the very early 2000s. When it first came out, a lot of people considered it a gay disease or something that only happened to gay men. That was never fully the case. However, that was the population for which was first primarily impacted in a very large way. Now, remember that that also was a group and a demographic that consistently had had a very different social stigma, had access issues to healthcare, had access issues and or hesitancy to seek out any kind of care when it came to any kind of STD. So you also see how socially that particular demographic got weaponized and villainized regarding this particular infectious disease, which caused outcomes that had that really socially that really influenced the community. You also saw a lot of action and resilience within that community and pushing for support for measures to fund research on treatments and things of that nature. So there also, while was really devastating to particular, especially big city, large communities of queer men, you also saw a significant amount of positive outcomes in the way of community-based outreach and public health information spread. So that was, so I'm not going to say that that was a good thing. That's not what I'm saying. But there, I do want to promote that that community itself did have a very strong response to that. You also see a lot of any kind of drug users who use needles or swap needles. Those are going to be really high with HIV infection rates and also hemophiliacs. So, and this was at the beginning, and it caused, again, that social impact, that social stigma. Now you see a more diverse demographic. So you're going to see less of that kind of really big swing or really big differential when it comes to sexuality based identities and who is getting HIV and AIDS. But you are going to see this very dramatic percentage or differential in percentages when it comes to the racial makeup of who is getting this. And again, that's going to come down to what kind of sex education. That's going to come down to whether you have access to healthcare. That's going to come down to whether or not you have had any kind of hesitancy to seek medical health care or not believe those things. And it also comes down to economic well-being. Let's see, about 1 million die from AIDS globally a year still. So this is still something that is very relevant. It's still something that is incredibly important to have conversations about. I'm not even going to try to, there are now current medications that really slow HIV infections. And these, I'm not even going to try to say the kind of medications they are. But these medications have really impacted in a positive way, because if you can get to them fast enough and you can get to them and you can start on them earlier, the earlier you start them and the more frequently or the more consistently you take them, you actually can prevent the spread of HIV and AIDS, even though you have it. Shh. Anyway, again, one of the biggest factors, and again, this is part of what I did, was comprehensive sex education. This is incredibly important when it comes to the conversation surrounding infectious disease, or as specifically sexually transmitted diseases. So, comprehensive sex education is incredibly important. Please promote that. I know that that is something that is really hard to do in some of the areas that we are, and especially in rural Kentucky. But it's something that literally can save lives, and it's something that's incredibly important. Again, there's a concern that HIV virus could develop more resistant to these drugs and cause another global epidemic. And again, that is really just down to viruses mutate. So we don't want that to happen. And part of that means that we have to, when we're starting to treat, and I think we saw that with the pandemic too, there's kind of a through line of needing to have a more global conversation about infectious disease, because we can't just leave economically underprivileged countries and or areas and or demographics unable to access things like vaccines, things like these medications that will prevent the spread. Because if we do that, what we're doing is opening ourselves up as a global community to more drug resistant and more vicious infectious diseases. And that is something that we will have to continue having a conversation about, and something that public health officials and are already doing. All right, so let's get out of here. We're going to finish this up, and I'm just going to go ahead and power through the rest of this because I think we can get through it fairly quickly. So we're going to have a few things to talk about here: discrimination and healthcare outcomes. So there's a lot of different demographics that have a consistency when it comes to being discriminated against within healthcare settings. And so we've already talked about a lot about how women of color, when it comes to any kind of conversations about maternal morbidity during or after post childbirth, and that being something that happens. But it's a more broad conversation that people of color in general face more healthcare discrimination and or being believed less. And part of that comes down to the demographic of individuals who have access to become doctors and their disconnect between those who they treat. And so when you have a less diverse population of individuals becoming doctors, you have a less perspectives to really be able to have a conversation about and understand the social impacts that happen to those that they treat. And so that's something that, as we are learning, we're having more, trying to stick more social science courses and or public health courses and or classes like this one into curriculums when it comes to pre-med or med school classrooms. And that's just because we need doctors to not just be informed about medical things that they're treating, but also the things that impact those medical things that they're treating, right? And this is something that overwhelmingly has been conversations within that particular field for an extended period of time. However, change is slow sometimes, especially when you're talking about textbooks and curriculum and things of that nature. All right. So occupational health hazards disproportionately impact the working class compared to the elite. So that's going to be something like when we talked about black lung in the miners, right? So when you work any kind of manual labor jobs, any kind of factory jobs, any kind of jobs that deal with any kind of toxic substances, all of those jobs are going to be individuals that are more in the working class as opposed to those who are wealthy. And or just the fact of working 40 hours a week is something that or more and or multiple jobs is something that those who need those economic resources more are going to be having to do, which puts an impact on your body more long term. Healthcare reform is definitely needed to reduce inequalities, but on top of healthcare reform, also because we have so much issues when it comes to access and cost, It is also having more conversations surrounding what healthcare for the entire country and for all those who live in it is going to look like or should look like, and why that would be so important when it comes to having conversations about economic equality and or racial equality and or gender equality and or just equality in general. Okay. Um, Again, we talked already about women of color and those care outcomes. When we talk about disability in healthcare, so anybody with a physical or mental, any kind of disability is going to have treatment measures that are vital to their, to really their quality of life. That's what I'm looking for. And due to those disabilities, a lot of times there are lots of economic hurdles that get in the way of being able to access some of those treatments. Sometimes they're just not, they're just more expensive, and or even things that make life easier, things like wheelchairs, things like any kind of aids that you need for vision, hearing, et cetera, et cetera, et cetera. All of these things cost money, and not all of those things are really accessible when it comes to what and how we pay those with disabilities in this country in order to exist. So really having conversations surrounding social policies um, for access and inclusivity for disabled persons is really needs to be a more broad conversation. You also have the healthcare of those who are trans and or non-binary and or intersex, right? These things require different kinds of medical doctors' knowledge, and those things aren't always something that is taught um, in medical services or in particular education environments for those, or even in continuing education courses for those individuals. And what that leaves is a lot of discrimination, especially against trans persons. There is a overwhelming amount of evidence that those who are trans actively avoid medical facilities when it comes to any kind of ailment that is not related to the actual doctors who help them in their transition. So anything like ERs, anything like going to the doctor for the colds or flus, or those kinds of things, they're going to get. They're going to actively avoid those treatments due to the treatment that they have experienced or others that they know have experienced because they are trans, and because they will get asked very invasive questions that have literally nothing to do with why they're probably there. Hey, I broke my arm. Okay. Why are you transitioning, and what are you taking, and is this okay? Those are going to have zero impact on the fact that I broke my arm. I want the cast on my arm, right? Like, and those things happen in very, very invasive and inappropriate ways. And that can leave really big access gaps for those individuals. Some companies will give rebates now for staying healthy and for their employees, but what that does is really um, promote a disadvantage and a discrimination against those who have health impacts that they have zero control over, right? So individuals who might have um, more invisible type diseases, so your autoimmune disorders, um, your long-term disorders. You're like I am a disabled person. I have a nerve um a neuroprocessing type issue that they don't know a whole lot about called CRPS. But because it is an incredibly rare neurologic disorder, it leaves things like when companies give rebates for staying healthy, it leaves people like me who have led fairly healthy lives but happen to fall and have nerve damage that caused this particular issue. um, it leaves those individuals without the ability to garner these rebates on their health insurance when they are the people that need those health insurance and it's vital to their quality of life, right? And so these are things that, while they sound really good, the practice of them also has this negative impact for particular social community or particular marginalized communities, including disabled persons. All right. Employees who spend less than their insurance deductibles are often given given the difference as a bonus. So again, that's putting people who are healthy and giving them kind of this initiative to stay healthy. But when there's things that people um, can't control, and they don't get this bonus money that could be economically really important to them, due to something that they had zero control over, or even like, you meet your insurance deductible if you decide to have a kid, right? Like having a baby's expensive, and you'll definitely meet that deductible for the year that you end up giving birth. However, your husband might not, or the father may not, right? Or the other person in the relationship may not. And that has a already inherent discrimination packed into it, right? Um, and then again, we're going to be thinking about how the healthcare system can be more humanizing to the people, and that's partly some of the things that we're talking about above this, right? That's all of it. It's having conversations about what trans healthcare should look like, how we can be affirming in those environments. It's talking about how we can have better policies to be more inclusive for those who have disabilities, right? And it's personalizing those individuals and understanding that in everything that you treat, there's a human element to it, right? There's a social element, and understanding that doctors need to look at humans like they're humans and not treat them like they're, I don't know. Sometimes they talk to you like you're a 2-year-old. Um, Understanding that there's a person on the other end of this, and a person that has this ailment that is impacting their life. And so not treating them like they're a bunch of boxes to check is incredibly important to accessing information that you may need to treat them. And so these are things that, again, are continuing conversations when it comes to the healthcare industry. And training must stress the inherent worth of patients. So you can't just look at patients as that 15 minutes that's going to get you that dollar signs, because when you do that, um, you defeat the purpose of why you're there. And so it's again, it's an ongoing conversation. It's not something that is always getting, it's not always being done right, but it's something that is continuing to be part of the conversation. And then correcting doctor shortages in those rural areas, or in those areas that are having those things, by creating competition and forcing medical professionals to be more personal. So when you tie this back into capitalism, if you have a bunch of patients that are not happy with you as a doctor, and you need those patients to keep your own lights on, you're going to have to change how you become a doctor. The problem is that when it comes to any kind of medicine, it's really hard to achieve that kind of pressure on the medical industry, because they can find patients elsewhere. Again, so how sociology can help. So physicians assistants and nurse practitioners. So while they make less, they tend to be more affordable, and they also come with kind of this stigma of not being a doctor, not being as knowledgeable, even though they go through an exceptional amount of school to get there. And they are limited in how they can treat. However, this has made some healthcare, especially when you're talking about things like giving vaccines, or you're talking about things like treating common ailments like the cold or the flu, things like that. Giving something that is a more economically feasible process for some individuals who may not have healthcare, may not have the economic means to go see an ER, or to have a physician that they can call, or a normal PCP. All right. So again, training physicians. So that lack of doctors driving up healthcare costs. So they just need to get doctors and nurses in there, right? So you're going to have nursing shortages. And this is something else that's being talking about in connection to the pandemic, having that burnout, right? Like if you continue to push medical professionals to work absurd amounts of hours, and absurd amounts of overtime, you're not going to get that personal experience. You're not going to be able to have those people that are being able to meet X, Y, and Z criteria. And that's just because at that point, they're just trying to keep enough bodies in the building to keep it to keep the medical system from collapsing in on itself. And that's something that as a country, especially after this pandemic, we're really going to have a conversation about how we're prioritizing our medical health professionals and what resources we are giving them when they have to go through something like a pandemic and watching those individuals die or putting their own self at risk of catching these infections due to their work. Again, governments could fund medical schools and or could fund policies that make medical schools more viable to a larger demographic and or more wide-ranging economic demographic. Assistance and motivation for rural care. Again, we've talked about this several times. And then again, the American Medical Association is likely to stifle some of these initiatives, and that's because their goal is to make this feel like the most prestigious thing that could possibly be on earth. And they're going to want to keep that and keep that as that like selling point. And in broadening that ability or making things more accessible, you also allow that ability to maybe make those costs less, maybe have those doctors make a little less, but also not having them pay back hundreds of thousands of dollars in medical school debt. So like there's push and pull in that, and you're always going to have your motivating factors that are going to work against those kind of things, and you're also going to have a social factors that are going to push for a need for those things. And we'll get into that as we talk more about economic systems and capitalism and how it drives a lot of these social issues. Home health care is another option that keeps popping up. My sister is actually a nurse in home health care. She does this for a living and loves it. And she worked in a hospital for a long period of time, but that was incredibly stressful and incredibly hard and taxing. And this offered a much better solution to being able to balance work life structures. But it reduces overall medical costs. It often is preferred by elderly patients and those who have movement restrictions because it allows them to not have to figure out how to get to and from the doctor's office, but also be cared for in the interim, right? So they're going to get their vitals checked. They're going to get the things, maybe help with baths or help with particular types of activities that they need in order to function and stay with that quality of life, but also not have to do so in a way that is disruptive and or economically unfeasible. And then you also have group homes and supervised apartments that can be used to offer some care for those who have more long-term ailments and or for those who are at a point in which they can no longer care for themselves. And then, something that your book talked about excessively and something that is incredibly important when it comes down to it, prevention. Prevention is the easiest and most efficient way to help raise and increase positive health outcomes. And prevention's due to issues like food and health safety, immunizations, preventing drug abuse, comprehensive sex education, and things like economic equality. When we talk about prevention, there is one thing that I want to mention about the book that, well, to an extent is correct, is also has its own discriminatory factors in it. And that's when we have the conversation about obesity in the United States. So when we have that conversation, there are a lot of factors that happen to that, but there's a lot of social stigma as well. And so you're going to see a lot of pushback, and you have been seeing a lot of successful pushback about fat shaming and just being able to be body positive in general. On the flip side of that, there is also a significant increase of issues with obesity due to economic circumstances, right? So when you have less access and or food deserts, they give you less access to more healthy alternatives. All of those things are going to impact your ability to essentially live on more healthy ingredients and more healthy foods. Also, time. if you're working 80 hours a week, you're going to grab and put in your face whatever you can that will get you closer to that bed faster, right? Like you want sleep, you're going to eat whatever's right in front of you that you can access quickly, and then you have to go back to work, right? And all of these things have these negative impacts on that idea of who gets to do healthy living, who gets to eat healthy foods, who can afford that kind of lifestyle. All of those things are going to impact essentially those obesity rates in the United States. On top of that, you're going to see a significant change in what we consider to be obese, what we consider to be unhealthy, who gets to decide that, and why it's so important to not have a social stigma attached to any kind of um, body type in particular. All right. So prevention does not promote like the problems with prevention, right? So it doesn't promote individualism. So it's not like me, 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 me. It also doesn't promote that freedom to indulge. It doesn't promote capitalism, and it doesn't promote instant gratification. All four of these things are things that are going to impact whether or not your messaging is heard when it comes to public health concerns. These are all things that came up in the pandemic. They're all things that can't come up regularly when it comes to any kind of conversations about how to stifle a public health concern. All right. It's also becomes less flashy than that heroic medicine, or that, hey, you got to the ER and all those things that we watch on the television is happening, which doesn't really work that way. But it's less flashy than this whole, well, I saved her life because I got to treat this particular ailment that was so close to death or what have you, right? Like there's this flashiness about how we treat medicine right now, and how we idolize doctors and nurses and put them on this particular hierarchical structure of what jobs are the most, create the most prestige. Okay. And without that, and if you switch to a motive that is primarily prevention, then essentially doctors are there to prevent what it is that they currently are operating to do. Right. And that becomes problematic in a society when the notion or coding is one thing, but the methods that would most help the society are the polar opposite. And then again, the nation's health would improve dramatically if the medical field would prioritize that prevention. All right. Lastly, again, this humanizing of healthcare, depersonalization has become very instinctive, but it's something that needs to be treated. Talking about medications too long. So it's something that doctors are going to have to deal with, and it's something that is particularly causing social discrimination among demographics. Training can prevent this, and it can, again, promote that worth of patients. Correcting doctor shortages, creating this idea. There's this idea behind do no harm, but we talk a lot about do no harm when it comes to medical ailments, but it also has to be a social conversation as well. You need more advocates when it comes to medical advocacy in hospitals, and especially in settings when it comes to language barriers or cultural barriers, things of that nature. So you need more cultural understanding and advocates that can help promote that, along with just medical advocates for those who have been doing this a long time. It is a lot of work for both the patient and any of those patient caregivers of anyone who has a medical complexity, to maintain and keep all the doctors talking, to keep the insurance talking to the doctors, to keep the pharmacy talking to the insurance talking to the doctors, to keep, like, all of these things have systems in play. But if you do not know how to work these systems, you will learn the hard way that it will impact your ability to garner and access the treatments you need, the doctors you need, et cetera, et cetera, et cetera. Education as a society, and also just having more educational opportunities for doctors who are already doctors in like more current trainings or more current continuing education courses. And then also social and medical joined research so that we can talk about the ways in which medical ailments and social factors combine and exist. And those things do happen. I'm not saying they don't, but continuing that conversation, especially when it comes to things that like infectious disease, things like common ailments and things like that leave individuals disabled for extended periods of time or at all. And then having conversations about universal health care is going to very much impact how we can humanize healthcare, because then it is not about who you know and how much you make. It is about access for everyone. All right. So the last thing we're going to talk about real quick, actually, I'm going to pause here and then I'm going to start a new one. And we're going to talk about the case of Ashley X real quick and why it's so important to talk about this case. All right. So I hope that this is informative and helping, and we're going to do this last lecture and then we'll be good to go for this module. If you have any questions, as always, please don't hesitate to reach out and I can talk to you about them.